Hello, my name is Eric Colhan, and today I'm going to be discussing skill retention and sustainment in regards to simulation technology with resuscitative medicine. Some of the key points for today will be the history of resuscitative medicine and the use of technology for skill retention in resuscitative medicine. What's the current state-of-the-art technology for skill retention and resuscitative medicine training? How skill retention technology in resuscitative medicine is used today and why it's important. How skill retention technology in resuscitative medicine relates to modeling and simulation, and where skill retention technology in resuscitative medicine is headed in the future. Before we can discuss skill, sustainment, and retention, or technology with resuscitative medicine, we first must understand what we're talking about with resuscitative medicine training. Resuscitative medicine training started a long time ago as basically rescue breaths. This was in the early 1700s, as far back as the 1500s. These rescue breaths morphed into the basic life support and cardiopulmonary resuscitation that we know today. Mostly you'll see this training run by the American Heart Association or the American Red Cross. These can be broken down into different levels of specialty, with BLS being the very basic, resuscitating any person that has lost their pulse or breathing capabilities. The next levels are advanced, ACLS, Advanced Cardiac Life Support, or PALS, Pediatric Advanced Life Support, for adults or pediatrics. Some healthcare providers may include TNCC, ATLS, or TCCC into the resuscitative medicine training category. As all of these trainings specifically involve trauma, these will not be recorded with basic resuscitative training medicine in our discussion today. A brief history of resuscitative medicine and resuscitative medicine training. The furthest back that we can find any documentation of any resuscitative medicine products, training aids, devices, or resuscitative medicine in general is the early 1500s. In 1530, there's documentation of rescue breaths being performed when someone stops breathing. Doctors at this time thought if there was no breath coming out, you should put something in, some sort of air. So what they used was a bellows. A bellows is basically an aerator for a fireplace. This is the first resuscitative medicine technology or simulation to be ever used or recorded. Fast forward about 200 years, and mouth-to-mouth is shown to be effective. Training for mouth-to-mouth was provided by other providers, doctors. 1850s through 1890s, doctors found that by turning or lifting a patient, lifting and relaxing the arms of the patient, they could get the heart to beat again. This was essentially the earliest form of compressions. Later in the 1890s, external compressions were shown to actually bring a person back, revive that person with a heartbeat, giving them breathing and heartbeat together again. Although this wasn't for another 100 years accepted as the norm. In 1956, the first defibrillator was designed, although this was not the portable defibrillator that we see today in airports and hospitals. This was a massive device that was connected to the patient and shocked them in a hospital operating room. In the 1960s was the first recognized CPR training that we know today. It was the basis of all the resuscitative medicine training that we've ever used. At this time, there were no adjuncts. The bellows was no longer used. There were no simulation aids, so something needed to be designed. We'll talk about that a little bit later. In 1979, the first Advanced Cardiac Life Support course was established, and in 1988, the first Pediatric Advanced Life Support course was established. The last three mentions, 1960, 1979, and 1988, were all the birth of current modern resuscitative medicine training that we know. Now that we've covered a brief history of resuscitative medicine and resuscitative medicine training, let's talk about the history of technology and simulation in resuscitative medicine training. As previously mentioned, the earliest known example of any adjunct for technology or simulation in resuscitative medicine training is the bellows. The bellows is that fireplace aerator that's used to put into a patient's mouth in order to inflate their lungs. Although there's very little documentation of it used in training, there is some documentation that Swiss physician Paracelsus used this with other physicians to demonstrate that it could re-inflate the lungs. It was a very long time from the bellows to the first true mannequin, or the first true technology and simulation for resuscitative medicine training. That's Resuscitative Annie. Anyone over 40 would know who Resuscitative Annie is. Resuscitative Annie was developed in the 1950s as the CPR trend for training was beginning. He got with a toy maker, Asmund Ladle, in order to develop a mannequin that was lifelike and that could respond to actions. This was the first time that you could practice chest compressions and breathing and actually see and feel the rise and fall of the chest. This teaching aid is very realistic and was very helpful to many, many people. Resuscitative Annie remains today as one of the basic standards for resuscitative medicine training. A little history with Resuscitative Annie. The mask that was used, and a version of it being used today still, was from the late 1950s, when Dr. Peter Safar decided he was going to introduce this. He was visiting Paris, and he saw a death mask of someone who had drowned in the river. He thought it was the most beautiful thing he had ever seen, and he used this death mask to be the mask for Resuscitative Annie. Some people think that Resuscitative Annie was modeled after Dr. Safar's daughter, but I couldn't find any documentation to prove this, where there is much documentation on the death mask from the woman who drowned. Resuscitative Annie was the original name, but was Americanized to CPR Annie. So you might see either on that large case that people used to drag up and down stairs and on shelves. Dr. Safar believed it was important to find a way to move resuscitation methods beyond the medical field and out into the public. Resuscitative Annie was used by providers, nurses, medical assistants, and by the general public. In 1981, telephone support became available for CPR. In King County, Washington, emergency dispatchers were trained to give callers CPR instructions while they waited for the arrival of EMTs. It took about a decade until dispatcher-assisted telephone CPR was standardized across the United States. The next big evolution in the history of technology and simulation and resuscitative medicine training was the SimMan, or the High Fidelity Trainer. In 2001, SimMan was introduced with basic cardiac simulation, lungs that would inflate, a pulse that could be felt, and was shockable. It was at this time that the world decided high-fidelity training was the future for most medicine. In 2009, the SimMan had its first true large revamp where it became 3G wireless. No longer did it need to be plugged into large crates, large outlets, large defibrillators. It basically had all the requirements packed inside of it, and then it was Wi-Fi. It had batteries as well, so you didn't have to worry about basically any types of plugs involved with it. SimMan continues to evolve today. The last thing that we're going to talk about for the history of technology and simulation and resuscitative medicine training is computer training and applications. Back to the 1980s, computer training was initiated with the help of the American Heart Association to give basic training for BLS. That morphed into online training for BLS, ACLS, PALS, and many of the trauma life support that we talked about earlier. As time went by and mobile devices became the standard of use, these training methods morphed into applications, or apps. Apps are a little bit easier to use than computer training. They can be modified easier, they can be updated easier, and today's day and age, most everyone has a mobile device that they can access. This allows the learner to access the training at their own pace and their own schedule and not have to go anywhere else. Of course, this is the cognitive portion with very, very little physical contact, very little practice. You can see different things in the simulation to discuss, to tap on, but that real feel with the high-fidelity mannequin is just not available with the computer training or computer application. The current state-of-the-art technology for skill sustainment in resuscitative medicine training is based on the last couple of things we discussed for the history: high-fidelity mannequins, computer or online training, and applications. Today's high-fidelity mannequins can do pretty much anything. They can talk to you, they can blink, they can cry, sweat, they can have seizures, they can breathe, or any of that can stop at any time. For resuscitative medicine specifically, these mannequins can tell what medications are being given, if the chest compressions or breaths are adequate, and they can track all of this and give feedback. They can also respond very quickly. If the incorrect medication is given, or if the compressions cannot sustain life, the mannequin would not be revived. In addition, one operator is needed currently, whereas in the past it needed a couple operators, and the operator can be in a different room, making just the mannequin there looking as realistic as possible. For computer or online training, that gives a great cognitive retention. It's pretty realistic in viewing, but you don't have that feel that you do with the high-fidelity mannequins. Computer and online training is easy to track. You can update it pretty easily, and has been proven to be helpful. Applications are the newest form of training in resuscitative medicine. American Heart Association and the American Red Cross both have skill retention training applications for resuscitative medicine. Just like computer training, these are mostly cognitive. Although you can see video of someone performing compressions, you get the basic concept, but you don't have that feel of doing compressions. Within the last 5 years, these applications have become official and can be used by pretty much anyone, not just healthcare providers. Skill retention in resuscitative medicine training using technology relates directly to medical modeling and simulation. When thinking about the technology with resuscitative medicine training, you think of some old adages. They may not be exactly how I'm going to say them or how you see them on the screen, but you get the understanding of it. The first one is see one, do one, and train one. So you see something happen, whether it's on the computer or you watch somebody do something, you do it yourself, whether it's on a person or a mannequin or a device, and then you train someone else to do it. This has been proven to retain cognitive and physical skill retention. The next adage is if you don't use it, you're going to lose it. Basically what this means is you've learned it, you've trained on it, you've tested on it, you've done well, you know the skills, you have that cognitive development and retention, but what happens 3 months, 6 months, or 1 year later? According to the studies that I've looked at, the different articles that I've seen for research, they've looked over 300 studies, and all of the studies have shown over the past 4 decades that adding simulation to resuscitative medicine increases skill retention for up to 2 years. Some of those studies show that within 3 months you start to lose some of those skills, cognitive and physical. The more you practice, the more you retain. The future for skill retention technology for resuscitative medicine training lies squarely on high-fidelity mannequins. High-fidelity mannequins will take over as a standard of training for resuscitative medicine. They allow you to see, feel, physically experience, and have more potential for recollection and retention than any other type of technology for resuscitative medicine. As high-fidelity mannequins become more and more specialized, they afford the errors to be made on these instead of on humans, rather than the live patient. High-fidelity mannequins become smaller and can be used in more and more spaces. This means that facilities, hospitals don't have to have a simulation center in order to have a high-fidelity mannequin. This results in a greater ease for the provider, nurse, medical assistant, or anyone to understand and practice the skills for resuscitative medicine. In addition to high-fidelity mannequins, the future of skill retention technology for resuscitative medicine training will fall with applications, or apps. Applications are changing and improving at a much faster rate than the actual simulation mannequins. As previously discussed, applications are easier to use, easier to access. They can fulfill a need for a broader audience. Less time is needed out of work, and it can be done on their own time. Applications for the technology, skill retention, and resuscitative medicine training should be used in conjunction with the high-fidelity mannequin. The two together have the greatest outcome for skill retention. The last aspect we'll discuss for the future of skill retention and resuscitative medicine training is the frequency. Although frequency itself is not a technology, using the two previously discussed technologies, applications, online training, and high-fidelity mannequins, will allow for the greatest skill retention possible. According to the American Red Cross, resuscitative medicine training courses should be taken about 1 year after the initial training. The reason for this is to have the best opportunity at skill retention. American Heart Association and American Red Cross both say that the course certifications are good for 2 years, but without consistent practice, you do lose those skills. So both of these organizations recommend that the skills should be practiced, if not used consistently, about once every 3 months. To do this, use the applications and the high-fidelity mannequins. The combination of the two increases skill retention, both cognitive and physical. In summary, we've discussed the history of resuscitative medicine and resuscitative medicine training and the use of technology for skill retention. We've talked about the state-of-the-art technology for skill retention and resuscitative medicine training. We talked about how it's used today and why it's important. We discussed the skill retention technology and resuscitative training medicine and how that relates to medical modeling and simulation. And we've talked about where skill retention technology for resuscitative medicine and training is headed in the future. Hope you've enjoyed this presentation. This concludes the presentation.